quite an entrance to the music. I was bopping along quite a bit. Hi, everybody. Michelle Cordero here, Director of Education at ASIS Massage Education. It's been a couple weeks since we went live, and happy to be back with you all and with another great guest that we have to talk about something I think is not talked about or not explored enough in the manual therapy world, and that's shared decision making and bringing our clients into the process the sessions that we're working on with them. So today I have on as our guest is Walt Fritz, who is a physical therapist out in upstate New York, back in near where I'm from. Just talking about weather earlier, and quite the difference here in Phoenix and upstate New York. And so he has a really great information and just I really got sparked about the curiosity about reading a lot and listening to a lot of what he was saying about shared decision making. I thought that would be really great for our students to be a part of that conversation. So let's welcome him on and say hello. Hello, Walt.
Hello, Michelle. Hello, everyone. Thanks for having me here.
Yes, thanks for being here, especially to talk
Yeah.
about something I think will be so great for our students and therapists in general. I don't think that we talk enough about this. But before we get into the shared decision making, can you tell us a little bit about yourself and first how you got into the field of manual therapy and how you're into now your seminars that you teach
Sure.
and kind of your background.
Absolutely. So I am a physical therapist since 1985, which is like so long ago now. Back in 1985, back in school, we had a little bit of manual therapy. Manual therapy, what is that, right? To a PT, manual therapy is often joint manipulation or spinal manipulation. But manual therapy, we learned massage in PT school. And, that, I don't know, probably 4 labs of massage made us legally entitled to use it, which is pretty kind of scary, right? But yeah, manual therapy used a little bit of it early in my career, and it wasn't until in the very early 90s that I began kind of drifting off the normal PT path, and I started taking some myofascial release and craniosacral therapy, which were pretty popular, and I guess still are popular now. I learned I trained with Barnes and Upledger, and I kind of really aligned with the Barnes approach. So much so that I kind of let it all else go, everything else that I was learning, and kind of went down that rabbit hole. And I went down that rabbit hole for a couple decades. I took that model. I took all the classes available. I became a teaching assistant for John Barnes. I knew that model really, really well. And, there's a lot of conflation, the whole concept of saying something is about the fascia and then doing something with our hands and we have positive results. And then we believe, oh, it must have been due because it was the fascia, right? And I got really, really in bed with that concept. And so much so that it was like nothing else mattered. I had these blinders on and everything was fascial and every intervention should be myofascial release. And, massage was just working the muscles. So that wasn't any good. And everything else had its limitations except our little secret society of fascists. That's what I like to call them now. Fascists.
Like that.
Fascists who, it was really heady stuff. And, it still is for a lot of people. It wasn't until the mid-2000s that I emerged from that program and left it due to some disagreements and kind of went searching on my own for, I guess, my own calling. And for a long time, I kept using myofascial release and calling it myofascial release and even teaching myofascial release in some real limited small seminars. But I was hearing all these other voices on social media saying, no, you're full of crap. Okay, you're full of crap because you can't just treat fascia. You can't just blame fascia. Everybody else had a story. It was the nerve story. It was the muscle story. It was the limb story. It was the weakness story. Everybody had these stories. And I did a lot of continuing ed training after I left MFR. And I learned a lot, but it confused me because like everybody had what they thought was the holy grail, when in fact, I think everybody was just learning really good recipes to help people. So, to kind of wrap this up, it took me a long time to see the forest for the trees there. It's like, maybe they were all on the right path, except maybe there was a common denominator with every single one of these interventions, with these models, with these modalities. Maybe the common denominator wasn't what we thought we were doing to the tissue, but the exchange, the interaction, the relationship that we were building with the person that we were working with, and not on or not to. And that was a pivotal piece for me in starting to move beyond what we think we're doing to the tissue and look at what we're doing with the human being. And I think not just as a PT doing myofascial release, but for your own students and alumni, you know, the concept of massage working a muscle. Can we really pick a muscle and know that any change is simply due to that muscle without nervous system influence, without contextual factors, without behavioral factors, interoceptive factors? There's so many factors. But I get it. Massage is about muscles. It's just, you know, if we could put muscles in parentheses and realize that that's a person that we're working with. We're working with an intact nervous system, with psychosocial being, with so much to offer if we just open up a dialogue and have a conversation with them.
Yeah, I love that. And like you said, massage is about the muscle, but we can't touch the muscle without touching the integumentary system, the lymphatic system, the nervous system, the fascial system. Like it's just, it's all
the behavioral system, the fears, the expectations, the values, everything. I just think, and everybody is shortchanging this process that you and I participate in by naming a tissue or naming a pathology that we think is at fault, and that we think we're selected in affecting with our touch.
Yeah, exactly. That's, I think, and I've heard, I told you I did a little bit of prep, and I've been following some of your work for a while, and especially with this shared decision-making idea, and in hearing that, you know, we have this ego around it, and ego can seem kind of like a negative connotation, and it absolutely is, but yes, there's a reason we stood behind something, we put money into it and time into it because we believe that that's what it's working. So how do we still, like, especially as students first learning, or even life students, right? Because even we're still learning out there after we're licensed. How do we take what we've learned and approach the session with being more open to that? It's not just what I'm doing in this moment, but there's might be other things doing. And does it even matter what I'm doing? If, like, what's the point, kind of thing? Do you know what I'm saying? Like,
well, there is a bleakness sometimes, I think, when we realize, you know, well, there's so many different approaches. Does it really matter what we do? In some ways it does, in some ways it doesn't, right? There's a lot of studies out there that show the specificity of our work is less necessary than we learn and that we're taught, both in school as well as continuing ed, and as well as our experience. I mean, there's some really cool studies, but really studies that really piss you off, because it's like, what do you mean we can get the same long-term results from general relaxation massage as specific low back orthopedic medical massage, right? That's really obnoxious to a lot of people, because they paid so much money for this medical massage certificate, right? It's not to diminish or demean what you learn, but realize that there is so much more than what we think is important. You know, I'm going back to my history. In MFR, you had to balance that pelvis, because if the pelvis wasn't balanced, right, bilaterally as well as anterior and posterior, if that pelvis wasn't balanced, don't even bother coming up here down to the feet, because we were told nothing will last. Well, you know what? We started the pelvis, and then we moved on, and it worked, and that became the reason, you know, the reason why let's go start at the pelvis. Well, then I stopped starting at the pelvis, and I just started where the person told me they had an issue, and it still helped. That should be troubling to us, but it's not. We then just package it as another modality. It's like, well, okay, no, we're using neuromuscular now instead of myofascial, and that's a different set of principles. But that should be troubling. How do we move on? I guess have the humility to see that, you know what, smart people are smart in this really niche way. We're all selling something. I'm selling shared decision making with my manual therapy. Myofascial release is selling fascia work, et cetera, et cetera. You know, can we take all these grains or form them into one mass that becomes the greater knowledge, versus each one of those grains is singularly truthful?
Right. Yeah, I love that. And so would you say, because you're still teaching, you know, some of the, I heard you talk about it, like you're still using your hands in a way that could be said that looks like MFR, or
Yeah,
still is
yeah.
kind of the same techniques. So we're still using the different tools that we have to our advantage, and what we learned about, but approaching it differently. Would you say that that's a little bit more of how we're like
I think that,
getting
yeah,
into the session?
yeah.
Yeah.
Um, I'm the first to admit that I had some animosity toward MFR and the people who I learned from due to some of the
Mhm.
things that happened, and so much so that I guess it kind of represented itself in a bitterness, right, for a long time,
Mhm.
that no, MFR is garbage and all that stuff. And I learned from that, I grew from that. Um, but now I'm fine recognizing the fact that I do things with my hands that I learned from Barnes and Upledger and other people in ways that are almost identical to how I was taught that. But I
Mhm.
think there's some key differences there, that instead of me being the person, the expert, right, who can find the problem and then figure out the solution, I'm using that model in a way where I open the door, and I ask you and expect you to contribute to the entire process, which goes counter to MFR and massage, where it's like, oh no, you need to give this person time and quiet so they can reflect and all those
Mhm.
things, and don't interrupt them. And the hell with that. Like, let me ask you questions. Let me know if this is important. Is this relevant? What
Mhm.
I'm doing right now, Michelle, does this feel like we're hitting the right notes to you, or should I change what I'm doing? And
Mhm.
occasionally I get people who stop seeing me because I'm
Mhm.
too much work. I ask too many questions.
Yeah.
I don't I don't express myself as an expert who will take care of them.
Mhm.
But I'm fine letting them move on to someone else who will do that with them or for them, right?
Right.
I'm looking for a therapeutic equal
Mhm.
versus this hierarchical, I'm the guru and you know nothing, I need to fix you, right?
Right.
And then, nobody says that when they're doing education, but there's a
Right.
lot of models that build on tiered learning, right?
Yeah.
Where the more you learn, the more you're going to know, the more
Right.
you'll be able to help this person. And that's true to a certain
Mhm.
extent. But there's one thing that is missing, no matter how much I learn, no matter how much training and experience I have. I don't
Mhm.
know what you, Michelle, my patient, is feeling and fearing and
Mhm.
hoping for and expecting until I include you in on that process.
Right. Yeah. So I can only imagine how hard this is for everybody, because I'm thinking, I'm a 20 plus year practitioner as well, and how many things I'm looking back and where people say, okay, your client may request this or want this, but you're the expert
Oh,
and you should know like where to go. And so is there a fine line between someone just being like demanding, this is where I want you to work, even though I know like someplace else might be more effective,
yeah,
or
yeah.
is that really what we should be throwing out the window completely and trusting what our client
Michelle,
wants?
how many times have you seen on the massage groups people complaining about the controlling patient, the
Mhm.
micromanager? They literally
Mhm.
tell me what they want me to do.
Yeah, all the time. Yeah.
What's wrong with that? They're
Yeah.
paying us. What's wrong with them
Mhm.
telling us what they think would be helpful? You don't
Mhm.
have to completely cave to them, right?
Mhm.
Are you a healthcare provider or a service provider? That's a big question, right?
Right.
Because if you're a healthcare provider, we often say, no, you can't dictate what I do. If you're a
Right.
service provider, we often hand it over to them and say, what would you like, right? But
Right.
is there something in between? The controlling patient is something that really bugs a lot of people. Are they really
Mhm.
controlling? Or are they
Mhm.
just saying to you or to me, Walt, you're missing the spot that I think is important? I
Right.
think instead of looking at him as a controlling, micromanaging patient, maybe we're missing an opportunity to connect with somebody at their core level of need and want and desire, right? I
Mhm.
think that's just something. It's just, I make comments on social media groups, and you know how that goes. It just blows
Mhm.
up in your face,
Yeah,
right?
I'm like, mm,
Yeah, yeah, yeah. See, I love a good fight like that, and
yeah.
my wife says, "Don't bother, don't even get engaged." And here I
Yeah.
go, head on, I'm not going to engage, and my fingers on the mouse 2 seconds later, right?
Yeah.
But couldn't you see that micromanaging patient flip that script and say, you know what? I'm asking you to listen to me as the person in
Mhm.
pain, as the person with an issue, and I
Right.
think that's something in our training and education that we could do better on.
Yeah, I think so too. And I'm just thinking of ways like thinking about how I set up a client, or how we're teaching our students how to, take your client back and do the intake and everything. I'm thinking like that kind of has to get thrown out the window almost to really get this in play, because there's like 2 minutes. Okay, where's her? Okay, get on the table. Okay, I'll be back. Lie down this way, and you're done in
Yeah.
like 30-second intake. And even if you take a longer intake, it's usually doing maybe a little posture assessment, maybe a, have them do
Mhm.
some active range of motion or something. But I don't think we have that communication where we're saying, okay, well, what would you like to get out of the session? Or maybe we don't
Yeah.
emphasize it enough.
Yeah.
Or
Yeah.
or even so during the session, we're usually like, okay, be quiet, like you were saying, let them relax during the session. And I think that might be a shift for a lot of people. That might be challenging for them to
Yeah.
say, okay, this isn't going to be a super quiet session. I'm not working at you or on you. I'm working with you. So
Yeah.
that's
I think a
probably.
lot of it comes down to the way a session is framed from the start. If you work
Mhm,
for someone who's selling you as a 60-minute massage, and there's an expectation that 60 minutes of table time, it gets more difficult. If
mhm,
you're selling yourself, if you're self-employed, or you've
mhm,
that relationship with your employer, it's like our sessions are an hour long, which may not be 100% table time, because what
mhm.
you have to say may be important, and that's part of our session.
Right.
If I could turn the camera to look at my room here, it would look like a massage room to most of you, because I have a power table and that's about it.
Mhm,
I'm a PT, but I don't look like one. At least my office doesn't look like one.
mhm,
But people come in here and say, the session is X long, but you need to be able to share with me what you feel is relevant to this session.
mhm,
And I could tell you, you're going to find a lot of people who feel that being heard, being listened to, given time to for them to be able to tell their story,
mhm,
that's worth that money that they're paying. But yet we rush them onto the table. If you
mhm.
have to rush them onto the table, there's still ways to keep that dialogue, keep it open, keep it
Yeah.
flowing. Um, I tell people right off the bat, I'm really different from people you've seen like me, because I'm
Mhm.
really needy. I'm needy because I need your help to figure out how to help you.
Right.
And if you're used to just sort of zoning out or fall asleep, I'm going to keep poking at you. And
Uh-huh.
sometimes it is literally poking at you to keep you from going there, because I want to know, not like in every single moment, but I'm going to keep checking in. Is what we're doing connecting to your issue in a way that you feel is relevant and useful? Okay, I use some
Mhm.
really odd phrasing. Does this feel
Mhm.
familiar? Does this feel like it might be beneficial? Are you
Uh-huh.
getting benefit from what we're doing? And a
Yeah.
lot of times, Michelle, people say to me, I don't have a clue. It's like,
Right.
okay, well, let's work on this,
Yeah.
right? Because I can tell you, when I was taught to work on a person's pelvis when they came in for headaches,
Mhm.
it took a lot of selling.
Yeah.
And for them to really trust me to spend X amount of dollars with this private pay guy, if that's what they're doing, private pay service, that why is he working on my pelvis before he can help me with my headaches, right? I may
Mhm.
end up getting down to the pelvis now, but you know where I start? And I hate this, but you hear it all the time in our profession.
Mhm.
Find the pain, look elsewhere for the cause, right? We
Mhm.
hear that repackaged all these
Yeah.
different ways, but you ever notice something? Whenever that person talks about the cause, it's always a cause based on the way they view the body. If you're a
Right.
myofascial release therapist, the cause is always a fascial restriction somewhere else. If you're a
Mhm.
craniosacral therapist, the cause is always a craniosacral lesion somewhere else, right? And
Mhm.
you know what? That should be troubling again, but it's not. I may
Yeah.
end up doing all that stuff. Going to those places, but the place I start is the place the person tells me, you know what, I have issues right here, and I'll put my hands right there and I'll say, help me find that, help me connect with that, and that's
Mhm.
where the process starts, by listening to them to the point where I respect them enough to show me how to start.
Nice. Yeah, I think we do. I know that was my training. It's like, okay, that might be where the pain is, but you don't chase the pain necessarily. You got to find the root. And that doesn't
Yeah,
always why not address where, especially for a client who's wanting to see that connection, that something that they just did right now is making a difference,
yeah,
and could make a difference. It doesn't have to be somewhere else. So
right.
that's definitely like
I think
wonderful.
one thing that confounds this is, especially for the experienced therapist who's done, continuing ed training and followed a tiered kind of continuing ed model, is, you know
Mhm.
what? It's fill in the blank. It's an inhibited glute, right? And they go
Mhm.
in and they do that stuff to the glute before they come up here to the headache, right? And the
Mhm.
person feels better. And
Yeah.
that's uber validation that they
Yeah.
were right, right?
Yeah.
But I'm sorry, that's not proving that you were right. We started a
Mhm.
relationship with the person of trust. There's levels of contextual factors and all sorts of factors
Mhm.
beyond you activating their glute that help with their headache. And it's
Right.
really hard. The more training and experience a person has, I think it's harder to sort of unpry their fingers from that modality empire that they
Yeah.
trained with. And
Mhm.
in terms of getting students, and I don't care whether it's a massage therapist student, PT student, SLP student, when you're still sort of minds of mush, right? I don't know.
Mhm.
This is all just a lot of information. I think it's actually easier to start before those habits really get ingrained. But you know
Mhm.
what? I was kind of almost old and almost like set in my ways when I left that MFR world and had to start fending for myself out here. And you know what? It's not easy work, but the more I learn, the less of which I'm really certain about.
Yeah.
Which is troubling to some
Yeah.
people.
Well, I think and this has come up in a few of our conversations that I do on the live stream with other guests that I've had on about like research, for example, in the in massage world, at least, there's not a ton out there that validates what we've been taught necessarily all these
Mm,
years. And I'm thinking in particular, the idea of like how much fluid we're actually pushing with a Swedish massage. It's kind of being questioned of
yeah.
how much we're actually physically doing. So again, it goes
Yep.
to that ego, like how much do we really think we're making this impact with this one technique we're doing, and we're not taking into consideration all the multifaceted prongs of this whole being and this whole person here
Yeah.
and what they bring to the table. So
Mm,
I think that's something to remember about, that we can't pigeonhole ourselves in what we're doing to assess and work on our clients,
yeah.
and get too caught up in the A plus B equals C kind of
Yeah.
thing.
But yeah, we still have to take the test. We still have to
Mhm.
basically, you've got to learn through all these different models, and whether it's Swedish or MFR or whatever it is you're learning,
Mhm.
right? I wish I could allow people to see that, what's being presented is a very niche concept on a very
Mhm.
broad human being, right? That
Mhm.
don't overtrust, right? Don't overtrust anybody. And
Mhm.
we were talking before we came on the air here about that concept of, well, my teacher said. It's like,
Mhm.
well, are they just parroting what they learned in their schooling and they're
Yeah.
continuing it? We all do it. We're all
Yeah.
guilty of it. But
Mhm.
realize that, there's so many different perspectives on the
Right.
work that you and I do.
Yeah. Yeah. And I say that all the time, and to repeat kind of, because we didn't say it live, but to our students is, this is what I know to be true for myself right now, and what my
Yeah.
approach is, and what I've learned, and what I've tried to research myself and try to see what the latest is. But please, don't go out there and defend me to the world if you find later on there might be a different approach that seems to work too,
Yeah.
because I'm not, massage holder of all the secrets of the realm here.
Yeah.
So, and all of our instructors, and I think we have a pretty good staff to say kind of the same thing. Here's what we know, but here's also, when I was back in school, back in horse and buggy stage, what they didn't know and what they were teaching incorrectly, of course, with things that we now know because research, and
Yeah.
things that we debunked along the way. So that's important, to
Yeah.
be able to question anything you hear.
Yeah. And that's hard in human beings, is
Mhm.
debunking or having somebody deconstruct what you believe.
Right.
It was difficult for me. My line in the sand was 2005, when there's a website called somasimple.com. And
Mhm.
Soma Simple, it's a neurocentric website. It's a forum site. It's less popular now. In fact, they have a Facebook group which is probably more active. But back in
Mhm.
2005, they were doing, and I'm going to air quote this, a deconstruction of myofascial release.
Mm.
And I heard about it. I was still deeply embedded in the Barnes program, et cetera. So I went on Soma Simple to defend my modality,
Mhm.
my colleagues and everything. And basically it was like 6 or 9 months of toilet flushing arguments. And they were presenting me with their facts on why
Mhm.
MFR was crap, and I wasn't listening, and I was just regurgitating everything that I had learned, and sort
Yeah.
of sort of factoids about MFR, and it never went anywhere. And I got kicked off the website so many times for bad behavior. And then I'd be let back on with promise of good behavior that I could never keep. And it eventually just sort of folded and closed because it wasn't going anywhere, right?
Mm-hmm.
The neurocentric model made no sense to me, and they saw no sense in my fascial model. So, but it wasn't long after that that I left the MFR model, and I started looking for a new bunch of friends and a new model. And I went back and I actually started reading all that literature, all the research, all the references that were given to me. And it was hard work, man. It was hard work because my brain was thinking, my native tongue was MFR, and these people were speaking all these different tongues and all these different languages. It was a lot of work, but it was really good work. No one has all the answers. No one.
Right.
I just think there's some answers that are less wrong than others.
Yeah.
I spend a lot of time deconstructing concepts and then building a new model from there using evidence. But you know what? We cannot ignore our experience as long as we don't feel that our experience is evidence. It's not. It's too biased to be evidence.
Yeah.
But yet, how many people do you talk to every day or read from every day who think that because they had luck that's hard evidence? It's just not.
Right.
So,
yeah. I know anecdotal evidence is great. Like, good. Your client felt better. Great. Yeah, it's wonderful. But not necessarily means like that there's proof in the pudding there for that.
Exactly.
And so you talked a little bit about not just having it based on your own personal experience. And I was listening to, I think it was two therapists and a microphone podcast that you did a couple years ago. And you brought up the Venn diagram where you have the three interlocking pieces that we have our experience as a therapist, right? And then the evidence that's out there, like the research. But then that third part is the part that now is like total new concept, right? Or better concept is the patient and the client's information. So what you're saying, what we're talking about here is having those all equal parts of the therapy session, right?
It's exactly what it is. Back sometime in the 90s, the evidence-based model became the norm in medicine, including physical therapy, right? And as it grew, as it evolved, it was represented as three circles or an equilateral triangle, okay? With one of the sides of the triangle is the published evidence that we're supposed to be working from. The second side of that triangle is the clinician's experience applying that evidence, right? So there's a bit of my input. And the third start of the triangle, or the third equal circle, is patient values and expectations. And when you really look at the evidence for the model of evidence-based practice, it was intended to have pretty much equal representation. One should not overpower the rest. But in physical therapy, and I don't care whether it's exercise-based physical therapy or manual therapy-based, it was tons of research, tons of clinician experience in this tiny little kernel of patient preferences and values. And when I started looking at MFR, and I think by association massage, I would kind of ask people, well, how do you feel that you're meeting the standards of evidence-based practice by getting patient values and expectations? And I think and I'm going to be a little glib here, but it was almost the equivalent of how's the pressure? And if the patient said yes, okay, then I sort of checked off that box. And, I know I'm being a little dismissive and minimizing of how some people might bring in patient feedback. But I think that we need to do so much more than just ask those simple little questions and then let them go back to sleep, or then we let our ego and our healer cloak take over and do all the work. I think we need to work hard to make sure that we're really meeting their needs and expectations.
Right. Yeah.
I had a conversation this morning with someone who was talking about me teaching a seminar with them, and there was she said something to me which I hadn't really thought about in years, but I learned it a lot in some of my trainings. The concept of listening to the tissues, right? Listening to the tissues. It's kind of a visceral manipulation type of concept, but I learned variations in all the different kind of trainings of that. We're supposed to be able to clue into what the tissue is telling us, right? We feel energy, we feel this and that. And I really look back at myself 15, 20 years ago and how I really was listening to the tissues or at least thinking I was.
Mhm.
And now I'm listening to the person, right?
Mhm.
I'm listening to the person and not what I perceive to be their issue. I lay it right out there, right?
Yeah.
I need your help to help you. Instead of me being this like super incredibly intuitive healer who
Yeah.
knows how to read your body, I just think there's too much risk with that. There's also too much
Mhm.
possibility of wasting their time and money.
Mhm. Yeah.
You know, just acknowledge that we're working with a complex human being and start including them with respect in the
Mhm.
way that elevates them to a position of shared decision making.
Yeah, I love that. You had mentioned earlier when you have patients that will say, "Well, I don't know," or, "I'm
Mhm.
not really sure how to answer that." And you said it's something that we have to work on. So do you have ways that you do that? Because I know I'm thinking even like I have first time clients who don't know much about how they're feeling. They just know they don't feel well. We
Yep.
have students that are
Yep.
brand new that when we ask each other to give each other feedback, they're like, feels great. Like, and I feel like once they get further in the program, start to really get sink deeper into their bodies,
Yeah.
they
Yeah.
give better feedback because they know what's going on a little bit more. But how do we help a patient or client in a short period of time that doesn't have 7 months to go through an entire massage program
Absolutely. Yeah.
to connect with that?
So let me just do a separation first between massage therapy as a whole body routine, right,
Hmm.
versus massage therapy as a issue specific type of intervention. Okay,
Hmm.
because I'm doing manual therapy from that specific problem perspective, right?
Right.
Um, so let's just role play for a little bit here. A
Hmm.
person comes in with something in their throat, in their neck, and we start putting our hands on them as an
Hmm.
evaluation.
Hmm.
We might do other things to evaluate it, but what I immediately let them know is, first of all, I want to do something here, Michelle, that you feel is relevant and potentially useful. Now,
Hmm.
when I start talking in those words, the brow immediately goes like this: is I don't really know what you mean, right? But I want to do something, Michelle, that brings that problem to your awareness. Maybe it makes it feel better.
Hmm.
Maybe it brings it to your awareness more, not making it feel worse, but
Hmm.
bringing the sensation more to the surface. Is what we're doing right now, Michelle, does this feel relevant, familiar? Or am I connecting to that feeling you talk about, that swallowing issue? Swallowing and voice
Hmm.
are a big part of what I teach now. Am I
Hmm.
connecting to that swallowing problem you talked about? And if you say yes, I'll ask you questions surrounding that. Does this feel like you want me to change anything? Would you like more pressure or less pressure? Does
Hmm.
this feel like it might be helpful? If you say, you know what, you're not quite connecting with it, I
Hmm.
may do things like, Michelle, put your hands right over mine and help me help you. Or
Hmm.
better yet, you put your hands up here and show me where you're feeling it, and we'll do this work together.
Hmm.
It's this in the literature. It's called an iterative approach. It's
Hmm.
back and forth. It's not me telling you what needs to be done. It's you and me working through this together, right?
Hmm.
So how do you do that? You put them on notice that, Michelle, what I need to do with this work that we're doing right now is I need to connect to that problem that you're paying me money to help you with. Okay.
Hmm.
I know a lot, but I don't know what you know about your own problem. So help me help you. I put
Hmm.
you on notice before you even lay down on my table or sit in my chair that I'm going to need your help throughout this process. And I think that it's like you're pre-training your patient, you're pre-training your students to not be passive and allow the therapist to do their magic, but make the
Hmm.
process where you both have value and meaning and importance in the relationship. And yet it does constitute or require almost a reorganizing of how a curriculum is run, just like
Hmm.
it's about reorganizing how a therapy session is done.
Yeah.
It's not easy work. Does
Right.
it help, or do you have any follow-ups to that?
Yeah, that really does help to so having that kind of that backup, those questions that kind of lead. And you do a very similar thing at the start of the 1 hour shared decision making little class you have on your website. And so just I'm going to toss
Right,
this up on the if I can
right.
find my mouse. Okay.
Yeah, that's a free
On,
class. It's a free class that we put up there. Um, I did it for a Canadian massage conference, and I just decided it was worth sharing. And
Mhm.
it kind of helps people get over the hurdle of this is really awkward work. It's awkward moving out of that role of silence, moving out of that role of being an
Mhm.
expert, moving out of that role where the patient is passive and is a receiver,
Right.
and putting us into levels of equality.
Right. Yeah. And that 1 hour, it's about a 1 hour recording
Mhm,
that you have. And the first was about 5, 6 minutes or so is you working with a patient, or maybe it's a little shorter than that, I can't remember.
mhm,
But doing exactly what you were saying about how is that connecting with that person. And what I loved about this seminar that you had, this little 1 hour recording, was all the resources that you had connected to it. So the you had a full page of different research related and articles and things related to the shared decision making process, which I thought very super helpful because there's a
yeah,
lot out there on it. It's not
yeah,
necessarily new, but maybe not as used or implemented as maybe it could be. Would you
right.
say?
I mean, to be blunt, I have paid content. We all have paid content, right? That when you're in my business, in terms of online courses, live courses, et cetera, live short recorded or live classes that I sell. But I also have a lot of free content like this share decision making, free content on YouTube, and tons of podcasts that I've done from the massage field, from the physical therapy field, and from the speech
Mhm.
pathology field. Um, and to me, those resources should be freely shared. I have a research page that's yeah, it's like, and it's not just a data dump. It really is a couple hundred resources long, and they're the resources that I use to support my seminars. It's the
Mhm.
resources I use to support the book that I've got coming out next month
I
on
saw
manual
that.
therapy. Um, it's really how, and it's not just manual therapy, right? It's about therapy in general. It's about behavioral science. It's about so
Mhm.
much more than just this little niche. Like I used to look and cherry pick MFR articles to put on my research list,
Mhm.
but I would never share one that had a negative outcome for MFR because it didn't fit my bias. So
Right.
I would cherry pick these positive papers. But I
Yeah.
think we really need to take a look at both sides of the work we do, right?
Mhm.
Here's another thing that really ticks off a lot of massage therapists, right? That you really have to look hard to find, number one, a well done study.
Mhm.
Number two, a well done study that looks at low back pain, non-specific low back pain, from a standpoint where you really have a really good sized cohort group to show that massage therapy is is significantly beneficial in a positive way for a large percentage of people. Okay, massage therapy is very helpful for back pain, but when you break it down into a research study, it's a
Mhm.
lot more difficult to do that study and prove the benefit when you narrow the range of what you're doing, right?
Right.
But Chris Moyer, who's a PhD in psychology, who's done a lot of research in massage therapy, he's got a couple of papers out there that talk about the repeatable benefits of massage for anxiety, both single session help for in the moment anxiety, but then
Mhm.
repeated massage for what's called trait anxiety, which is what most people with an anxiety disorder have. And
Mhm.
that it somehow bursts the bubble that you're able to intervene on something from physical versus an emotional. But to me, I think that is so wonderful because we know that massage and myofascial release and all the manual therapies can be quite useful for someone for low back pain. But
Mhm.
someone with low back pain is also typically suffering a hunk of anxiety, right? Seeing
Mhm.
our work as being broadly applied may not quite scratch that itch that you want to become a medical massage therapist so you can do specific things. But
Mhm.
when we realize the grander context of these papers, that we have the ability and the potential to reach people at the biopsychosocial levels and not
Yeah.
just the biology of what we think is going on with their tissues.
Yeah. That's it. It's pretty powerful. That's yeah.
Yeah, it really
Go
is.
us.
Yeah, go you, especially if you can allow that not to be seen as something somebody's diminishing your impact, but actually
Mhm.
they're broadening your impact.
Right. Yeah, I just love it's so far reaching and yeah, just things that we can potentially do is amazing and that we don't have to be so caught up on what exactly is happening on the micro level, right? It's just
Yeah,
more of the overall big picture. So I think
yeah.
that's great. I love that.
Yeah.
And so let's see. I just want to make sure I got all my notes here, that everything that we were talking about. So what would you say to a student, since most of our a lot of our audience is our student population, of how do I, little old me, who maybe is just starting out here, going to talk this person who's been dealing with this pain for a long time into allowing us to have this kind of relationship, when all up to this point they're used to someone just telling them what to do and how to get on the table and what I'm going to do for you. How do I find my voice? How do I start the baby steps to get into that position?
Yeah. Oh, it's so difficult. Well, it's so difficult walking in the first clinical room, right? Where you first actually
Mhm.
have to touch another person beside
Yeah.
one of your cohorts,
Right.
right? Um, I I I personally think that there's benefit in being really blunt and saying, you know what, the way I work may not resemble what you've had before when you've had massage. And I
Hmm.
think a wee bit of education is important and I'm sure that you instill this in your students, but it's also good for the student and the therapist to instill it in their clients that even though we have this thought bubble of what massage is, a massage therapist has the potential of a much greater role and broader role, right? We can do that 60-minute session where we get your front to back, top to bottom in a way that a lot of people really find that incredibly helpful, right? And if
Hmm.
that's why you're here, then let's do that. If
Hmm.
you're here for something more specific, I put it right out there in the beginning. Are you okay? Or would you like me to focus on this neck issue? And then I shut
Hmm.
up and I let them
Hmm.
kind of chew on that. Well, wait a minute. You mean I get choice in this? Yeah, you do, because we
Hmm.
don't have to work your whole body if the neck is really what you'd like to spend time on. And sometimes that starts a really nice conversation of, okay, this person is different, right?
Hmm.
And I'll literally, even with my patients, let's say a patient comes in with three things. They got three things that they put on their history form. I'll say, okay, Michelle, how do you want to break up this time today? Do you want me to do, a third on each of those? And they might say, yeah, let's do that. And I'll say, okay,
Hmm.
and I'll check in with you at, when we hit that time where we're about ready to a third. Because sometimes they'll say to me, I really like what you're doing. Why don't you spend the rest of the time here?
Hmm.
Or they might say, no, I do want you to still get to that, right? And
Yeah.
if you can kind of hook them, and it's a hook, right? We're
Hmm.
we're saying we're doing things differently. I may not do massage the way, because I don't do massage, although a lot of massage therapists do MFR, or a lot of massage therapists take my classes for whatever I call my stuff, right? Manual therapy. It doesn't resemble massage, but yet I'm a licensed therapist who can do this big, broad umbrella of things. It
Hmm.
takes a lot for a student to move beyond that comfort zone of what they expect themselves to look like, as well as what they think that others think they look like. I
Yeah.
teach this work to speech pathologists, right? And speech pathologists are exceedingly self-conscious about adding new stuff to their toolbox, right? And then
Hmm.
I remind them that unlike a PT or a massage therapist, when a patient goes in to see a speech pathologist for the first time, they typically they don't have a freaking clue what they do for a living. And that's
Yeah.
perfect. It's perfect because
Right.
now you can start touching people and doing this work, and they won't know that that's not what you do for a living. Now, as a massage therapist, that doesn't apply in a way, because
Right.
we all have this thought bubble, or we think we have that we have a thought bubble that this is massage, this box, this small box of things.
Hmm.
Realize that you, as a future massage therapist, have the potential to do this broad range of interventions, and start early. Start early, right? I
Hmm.
can do massage as you thought about it. And by the way, you can do shared decision making with traditional lotion or oil based massage. I don't
Hmm.
do it, I don't teach it, but you can easily do it, right? Does this feel useful? Are we doing
Hmm.
something that you feel will be a benefit for you? I
Hmm.
love asking that question,
Yeah.
letting them decide. And if you can get your students to start asking those questions, I think it's just going to turn this whole world on its ear a little bit. There's absolutely nothing, there's nothing wrong, and there's everything right about traditional massage. But
Hmm.
then what do you do when you get out there with all these other variables facing you, all these other options, and everybody's sort of clamoring for your money to sell you these products of, here's all these different modalities you can learn. Take them, learn from
Hmm.
them, but bring them back and put them in the context of the patient, not in
Hmm.
the uniqueness of the fascial model.
Right. Yeah, I almost think, I'm just thinking now about how maybe that's even might be easier for a student to be like, okay, I'm not the expert yet. Because I know that's hesitation the first day in the,
Mm,
in clinic,
yeah,
you're like, I don't know enough. That's okay. You're not expected to. And this is where we rely on our clients now to communicate with us so that they can help with this process. So
yeah,
I'm
yeah,
almost thinking that's a way out from not having to look like the
yeah,
expert when you don't feel like
yeah.
it.
I think there is there's part of the fake it till you make it type of concept, right?
Hmm.
And I'm sure that in some ways you instill that in your students, right? That we're not going to lie to a patient that we
Right.
know all this stuff, but you don't want to let on that you're a complete moron, right? I want to not come off like a dolt, right? When they say, "Well,
Yeah.
what do you think, Walt?" There was a time when I said, "Well, gee, I don't know," and I left it at that. I left it hanging.
Mhm.
And you saw them sort of checking out right away. It's like, I'm paying this
Yeah.
guy money and he doesn't
Right.
know. But
Yeah.
now, when someone says, "Well, what do you think?" I have learned to be comfortable in my own body and self saying, "I don't know for certain. Here's
Hmm.
a couple possibilities.
Yeah.
What do you think? What do
Right.
you think?" Right? I might say, "Okay, your doctor said you've got you're low to a trigger points." Right? I might say to you, Michelle, it could be what your doctor said, that you're low to a trigger points, or, and here's where we insert uncertainty. It could be that it's a neurologic remnant from an injury or something that happened in the past that your nervous system hasn't let go of yet. I
Mhm.
let them know that there's at least two possibilities there. Introduce
Mhm.
uncertainty, and then I turn it around. I say, no matter
Mhm.
whether it's a trigger point or a neurologic holding pattern, does this feel like we're in the right area? Does this feel like it might be helpful for that problem? Right? That's
Mhm.
something that you it takes a while to find comfort or to be comfortable um, not knowing. Right?
Yeah.
I've gotten really comfortable not knowing and telling
Yeah.
people that I don't know everything at all.
Mhm.
But that's why I need their help to figure it all out.
Yeah. I think from a patient point of view, I've me going to somebody that would always make me feel better. Like they're human, and we can have. I don't have to feel like they're that again that differential kind of
Yeah,
treatment with, being that power differential is what I meant to say. So,
yeah,
yeah, very reassuring, especially when you're going to be trusting this person with your body for an hour. It's
yeah,
nice to
yeah,
know that that other person's just a human being too. It's
yeah.
going to help you as
There,
best they
there is a
can.
caveat in there though, because a lot of patients come to us in a traditional biomedical model where
Mhm.
they expect to be the submissive, the non-dominant person in that relationship.
Mhm.
And I find in my clinic here that it's a struggle sometimes with that person. Some
Right.
people, they come in as the boss already, right?
Mhm.
Maybe you'd call them the micromanager, right? They want to
Right.
be the powerful one.
Yeah.
Most of my patients are willing to give a little bit, to flex a bit, to come up to the level that I'm asking them to share power. It's all in any relationship, power is always fluctuating, whether it's a
Mhm.
personal one or a professional one, right? But ideally, I think the most successful relationships are the ones that generally even out. But the ones that are really tough are the people who don't have it within themselves to see themselves as having enough power, knowledge, information to give worthwhile input. And that takes a lot of work on my part, and it will on your students'
Mhm.
part, trying to elevate that person. And some people never quite make that or never make it at all. And occasionally, I hate it, but occasionally I will take on the power role. Um,
Mhm.
but I keep working, I keep empowering them, I keep
Yeah.
educating them to see if I can bring them up to a level where, you know what, we're sharing it now.
Yeah. I love that. Um, Beautiful. So I know if everyone's more interested in that 1 hour, that the free class that you have on the shared decision making, it is on your website. And you do have the sign up for the newsletter, which is amazing and chock full of information as well. So I highly recommend anyone who wants to follow
Yeah.
your work to go ahead and do that. And excited about the book coming out in March. That's
Yeah,
exciting.
yeah.
So
There's
just
also another free long hour one on, well, what's your beef with MFR? Now,
Mhm.
I don't know how much your students know about MFR, but once you get out there, you're being bombarded constantly with these continuing ed stuff, with all these
Mhm.
acronym based things, and
Yeah.
there's a lot of real loyal followers, the tribe of MFR providers out there that I get this all the time. It's like, why do you have such a beef with MFR? So I decided to do a little video on my talk with what's your
Okay.
beef with MFR. I know a lot of people unsubscribe from my newsletter because I'm so um, maybe anti MFR, or I'm
Mhm.
not afraid to question. the gurus, right?
Yeah.
And I don't want to be a guru ever. So there's that one's a big long free one too. So
Yeah. Oh, that's awesome. I love people should check that out. And we're getting close to our time, so I want to make sure that we have a little bit of time to get to know you with our little hot seat questions that I did send you ahead of time. And before we do that, is there anything else that you want to share about the students should check out on your website, or things to come down the road, or anything like
No,
that?
like everybody else, I'm selling something. I sell live seminars. I sell online seminars. You know what? It's out there if you want it. But there's also a lot of good free information. I think as much of this should be out there for us. And yeah, there is a way to learn hands-on work that is best in a live version, but you can learn hands-on work once you have the basic frame for it through online videos, and whether that's online trainings that you pay for free or whatever, or books or whatever. I mean, yeah, I don't really need to go too much into my website. Sign up for the newsletter if you want to hear, me talk about stuff. But other than that, you can just work your way through the website.
Awesome. I love that. Well, thanks so much. So let's find out a little bit more about you, Walt. So which talent or superpower would you most like to have?
So, I'm realizing this probably sounds a little packaged, but honestly, it's patience.
Oh, wow. That's a new one.
There was a study that I wish I could put my hands on, because it's probably 25, 30 years ago that I read the study, where they surveyed PTs, OTs, and speech pathologists. And basically, they fed them a question. And I don't remember how the study went, because, it was a long time ago. But basically, what they were looking for in the study was which profession allowed the least amount of time before we inserted another question, or before we started talking. Basically, which one was more patient and which one wasn't. And PTs failed, man. We were the worst. We were just like blasting people. And I recognized that in myself at the time, and I recognize itself in myself now. And just allowing not just my patients, but another human being that time to give their side of it. Okay. So patience.
Oh, I love that.
Yeah.
If you weren't a physical therapist, what occupation would you most like to have?
For most of my adult life, I've always thought I would like to be a chef. There's something about that, the creativity and expression, that I always was. Well, I'm the cook at home. I love cooking. I love exploring. When I really watch some of these cooking shows and see what kitchens are like and the hours they work, this is a fantasy we're talking about here, right?
Yeah.
But yeah, I think that would be it.
Yeah, I do like those movies and things they paint around it, where it's this really fun, glamorous life sometimes. But yeah.
Yeah, but then you go home smelling like a fry fry machine. It's like, no, I don't think so.
Yeah, dish soap and things like that. Yes, absolutely.
Yeah.
Old dishwater. If money and circumstances were not issues, where would you most like to live in the world?
Hawaii.
Hands down. Do you go often?
I get to, yeah, more recently, yes, I get to teach there on a regular basis in Maui. And my wife and I have been fortunate enough that we tend to go most Januaries, not this year, but yeah, I think it would be Hawaii, especially Maui.
Awesome.
Yeah.
Oh,
yeah.
Very cool.
Yeah.
What is your most treasured possession?
Two things. Now, this is going to sound really cheesy, but right there, that's one of them. Okay? My wedding ring, my marriage. It's not a possession. It just is what it is, right? That really is one of my the treasured things in my life. But the other one is really kind of strange. When my mom died a bunch of years ago now, I was going through a box of her stuff, and I found this tiny little leather wallet that was, it was ancient, right? Almost cracking. And inside of it was a picture of her and my uncle, her brother, when they were babies. And it was just this tiny little wallet of her that I just think that it's like, yeah, that's, and I never really thought of what do I have as a treasure possession, but when I thought about it, that really is it. So there you go.
Oh, that's so sweet. Oh,
yeah.
That. And then last but not least, what would you tell your 18-year-old self?
It gets easier. Don't sweat it. Yeah, it does. Yeah. Getting comfortable in your own skin. And that took me a long time, but I think I'm finally comfortable there. Yeah.
Yeah, and now you're starting fights on the internet and that stuff, so that's great. You're very comfortable.
Yeah.
Love it.
Yeah.
Just man of conviction. I love it.
Yeah.
Well, so thank you so much again, Walt, for joining us today and giving us lots to think about, and also how we're working our sessions. And I hope our students start to really challenge themselves to follow the shared decision-making process with their clients. So
Got
I
it.
really appreciate your time today.
Thanks for having me. And I just want to put this out there as a, legitimate comment. If you or any of your students or anybody watching this has questions, don't ever hesitate just to reach out through social media or for an email. I enjoy conversation like this. I enjoy that process of learning from each other. So, and I mean that.
too.
So, but thanks for having me here today.
Yeah, absolutely. Well, take care and enjoy the book launch next month. So excited for you.
Thank you. Thank you.
All right. Okay.
Bye.
We'll see you next time.